more so than in younger patients with good quality bone. So let's see if we can get these cases up here. Okay, so I apologize for the x-ray quality. The hospital has made it difficult for us to pull x-rays to share in presentations, so they're a little grainy and we're working on that. But here's a bimalleolar ankle fracture that is in about a 68-year-old osteoporotic female, limited ambulator. And you can kind of get the sense that she has some poor quality bone. The question with these fractures is, how do we go about fixing them? I think there's a lot of options. I think in this particular fracture, the question is, do you need to fix both the medial and the lateral malleolus? Do you use regular plate fixation, or should you use locking plate fixation? How do you augment the fixation, if you augment it at all? Or perhaps in this case, you should just go to an intramedullary nail because of the bone quality. I think probably the latter option of a nail is extreme. It takes away motion and you're really counting on a fusion. So in this particular case, I elected to fix it through standard means. Here's the intraoperative photo where we're using a 1/3 tubular locking plate. You can see that the fracture has been reduced with a clamp. And ultimately, we secure the buttress type fixation with locking screws, and we get a reasonable reduction of the joint. And I think if you go back and look at this x-ray, you see that the medial malleolus fracture is below the level of the axilla. This is a diabetic female, poor quality skin. I guess my question to the group, and perhaps some comments at this point, would be, A, do you agree with the approach? And B, should we or should we not fix the medial malleolus? Any comments? Hello.
Here's Guilherme from Pelvis Club.
Oh, hello.
How are you?
I'm doing well.
Yeah. Professor, in this kind of case, I always prefer an intramedullary nail because the quality of bone. What do you think about?
Well, I think the intermedullary nail is certainly an option, and a good option in a low demand patient. This patient was a relatively more of a community ambulator. So I think if I can preserve the ankle motion, that might be better in this age group. But I think you're right. In a low demand patient who's of advanced age, maybe only ambulates around the house, that might be a really good option.
Perfect. I agree with you. Thank you, Professor.
Yeah. So we can, so there's what it looked like. I chose in this case not to fix the medial malleolus because I thought we had a stable reduction. And so here's where we ended up about 6 weeks into this. So with fixation failure, total failure. And this is my case. I own this case. So the intramedullary nail would, in hindsight, is looking to be a very good option here. So what do we do now? No infection, no signs of infection. The skin is okay. Patient's uncomfortable.
Probably it's a Charcot arthropathy, isn't it?
Yeah, yes. Certainly Charcot in the diabetic patient is a factor. And when you see rapid failure, I think that's you know, a common diagnosis to make is Charcot arthropathy.
So it's with 6 weeks, it's possible to try to save the joint. So I remade the osteosynthesis with a locked plate and augmentation of the synthesis with many screws from fibula to tibia, and with the screws in medial malleolus, if it's possible to rebuild the joint. I'd like to need more exams, like probably a CT scan or something like this.
Yeah, I think that's having been burned by my own fixation and looking at the impaction of the lateral joint, and knowing that the bone quality was poor, I was not so aggressive in trying to salvage the joint at this point, and I opted for the nail. But I think you make some good points. I think in another patient, maybe without diabetes, I felt like we had one chance to kind of get this right. So that's the lateral X-ray of the failure. So we moved on to a retrograde calcaneal nail. And so we went ahead and performed a primary ankle fusion. Now, the question that I have for the group when you do this is how many people choose to formally fuse the subtalar joint? We formally attempted to fuse the ankle joint, but how many people decorticate or prepare the subtalar joint for a fusion in this setting?
No, I never do that.
You leave the subtalar joint alone.
Nobody has an answer. Nobody has a question.
I have.
Okay, go ahead, Dr. Isaac.
I don't understand why you didn't fix the medial malleolus, because the stability, the medial side is very important to the stability. I think that if you had fixed the malleolus medial, you don't have this problem.
Yeah, I think, I think you make a good point, and that might have been an error in my judgment. The reason I didn't fix it was because I felt that the fracture was below the level of the axilla, and so that we had containment of the talus on the medial side. That was the reason why I didn't fix it. I think you can argue the failure pattern here, which is more of an abduction injury with an avulsion here, that I think you're probably right, that this was you could have conferred some stability on the medial side. I don't know if that would have prevented this rapid failure, but I think in these patients, you're always trying to balance, too much surgery, poor skin quality, poor healing quality. But clearly in this case, what we did here was not enough.
Because I think if you have put
dear professor,
an encerclage, tension band, static tension band, you would not have this problem.
Yeah, maybe. You might
dear
be
professors,
right.
I would like to make a chance to talk about, with these patients, I prefer to use a long plate in the fibular to put some screws passing through until like a plate. It's a long plate. We've put some screws in this place and not put the screws in the other holes. Okay, it's a long to fill to distribute the strength along the plate.
So I think what you're referring to is the technique of where you use a plate and you place long screws to gain additional fixation into the tibia to keep the plate from pulling away.
Yeah.
Other techniques would also would include, say, additional K-wire fixation intramedullary in combination with the plate. That would be another option, I think, here. All viable options in poor quality bone. So I think points well made. Now, what I wanted to point out is this did go on to fuse. We confirmed that with a CT scan. There is a total knee above this, so it's a shorter nail. But what I wanted to point out is here's the initial post-operative X-ray, and things look good initially.
But probably we will feel there's a big stretch along the tibia medullary tibia, and probably fracture in the medial tibia. Probably it will be.
Yeah. Well, this is the more, I think we're about 3 to 4 months out here, but look at what happened here. So you can see the total knee above, but with early ambulation after surgery, the nail fixation in the talus and calcaneus failed and the nail became proud in the bottom of the foot. And patient complained of pain. So my point here is, even if we use the most aggressive approach early on, the bone is always probably the biggest factor here. So the compression that occurred into the tibia probably allowed us to achieve a good fusion here, but we still ended up with prominent hardware. And I think one of the challenges of retrograde nailing is, particularly in poor quality bone, is we don't always get good fixation in the calcaneus or the talus. So ultimately, this fused. We took the nail out. I don't know if I don't have a picture of that, but things went well after that. But I think this represents a lot of challenges in the lower extremity, particularly in ankles. But I'm open to your criticism. This is my case, my decision making, my salvage. I have no one to blame but myself.
Hey, Steve, if you want to, you can go for the next case because
okay.
You're a very brave man.
Yeah. So this is a proximal tibia case. I got a lot of things going on here, but this gentleman is a diabetic male, comminuted interarticular proximal tibia fracture. It was closed with a very prominent piece of medial cortex pushing against his skin. Relatively low energy mechanism, if I recall correctly, just a trip and fall coming down some stairs. Gentleman's about 74 years old. So any comments on how to approach this initially, long term, from the participants?
I would like to put a circular hybrid external fixation with a ring in the proximal tibia, and probably to put along the tibia two or three screws with like monolateral.
Okay. So like a hybrid frame.
Yes, that's it.
Yeah.
That's all.
Okay.
Thank you.
So avoid an incision altogether. Go for a hybrid frame, stretch things out. Certainly an option. I think, I always get concerned about hybrid frames and diabetic patients, but it's certainly possible to manage them that way. Any other ideas? Okay, well, I'll show you what we did. We went ahead and initially we just put a spanning fixator on. We weren't in love with this fracture fragment that wouldn't really come out to length here. So we made a small incision here and just pulled the fragment out. And at that point to get the tension off the skin. But now what? Anybody going to plate this? Is that what the group would do? Put a plate on there, make an open incision? How many people for that versus a percutaneous plating? Any idea? Yeah, go ahead. Any comments here on this?
There is an article, I don't see, I'm not seeing. There is an articular fracture in between the two sides. Do
you have the oblique views?
No oblique films. I'm not giving you very much information, I guess. I didn't show you the CT. I will tell you the fracture into the joint is relatively non-displaced. And again, an older gentleman's mid-70s, diabetic.
I would put double plate, one on the medial side and one on the lateral side, both with locked screws.
locking screws, medial
Yes.
plating, locking fixation. Okay, all good ideas. I worry about the number of incisions. So in this case, we took him to the OR. We got rid of the offending bone. We actually allowed him to impact here and shorten. And we utilized a percutaneous plating technique with a locking plate and in the shortened position. And we used the plate as an internal fixator. We used the plate with some standard screws to affect the reduction into an optimal position, and ultimately fixed him in a shortened position to try and gain some stability in the area of metaphyseal comminution. So that's how we chose to treat it. So we actually, like, not dissimilar to what you might do in a proximal humerus, where you may allow the shaft to impact into the head if you want to achieve some stability from the fracture itself. So tell me, how many people think this might fail?
I do.
Okay, so you're voting against me again.
Yeah. I would fix the medial side.
Which is okay. I didn't bring all my failures today, though. Just a few of them. But this guy actually did okay. So he did, because he was recumbent a lot. I think in these older people, particularly in the diabetics, you got to worry about positioning and heel protection. He did develop a heel decubitus ulcer, which wasn't really our goal. We were trying to get him to walk. That eventually declared itself. But just to point out in our elderly patients how important it is to take care of the whole extremity and the whole patient, and be aware of these complications. So it wasn't a complete success for me. And here you see it resolving over time, and eventually it went away. But here he is. I think this is, I can't see around what's going on here. I can't, how many weeks post-op does the slide say?
6.
6 weeks. So you see at 6 weeks, we're maintaining the reduction in the shortened position, but he's making a lot of bone. So from my standpoint, his wounds are closed. He's not draining. His joint looks good and reduced, and he's making bone in the shortened position, and the fixation looks intact. So here he is. Again, I can't see my top slide, but I think we're further out, probably at 3 months.
5 months.
How many?
5.
5 months, yeah. And so we think he's healing. And I know, you know, that sometimes in the geriatric fracture patient, the x-rays look a little ugly, but we got to remember we're not cosmetic surgeons of the x-ray, we're functional surgeons. And so the whole idea here is to get this guy moving. And so here he is at, we'll see if we can get this to run. This is his clinical result at 5 months. Like I said, an older gentleman, and he's ambulating with his walker, and pretty functional. Happy patient and doing pretty well. So
congratulations.
Congratulations to him, I think, not to me. I just feel like I dodged another bullet. But I think here it's fair to say in some of these fractures, you know, shortening them is not a bad idea, particularly in a comminuted fracture if it confers some stability, because then you're getting the bone to share part of the load. But it would be great to hear some comments.
In my opinion, it's you have a very good solution for this case, and they were very happy. Probably the patient is very happy too.
Yeah, I get a little worried. I mean, I think the challenge here about the two plating, and you can certainly do it with percutaneous techniques and get some stability, but I think we have to be really careful with, you know, balancing what our x-rays look like and the amount of stability that we were trying to achieve, with avoiding wound healing problems or inducing, you know, biologic damage. It's always a balancing act. And sometimes we win and sometimes we don't. Okay, so here is what's becoming not an uncommon problem in the geriatric or the fragile patient, and that's some sort of arthroplasty in the upper extremity and an associated periprosthetic fracture. So this is an older female patient, previous fracture here, or a previous reverse total shoulder, and a fracture around the tip of the prosthesis. So what does anybody do with this? I don't think we're going to put a longer prosthesis in there, and I'm not sure I'd recommend that, but I suppose one option is non-operative management. And always a discussion as to when that's good and when that's bad. And then the other option is some form of operative fixation. Any thoughts? And of course, the challenges are, where do you get the fixation at with that giant prosthesis? I know there's some upper extremity surgeons in the audience. What do the joint surgeons that do reverse total shoulders do with this? Clearly, you must be seeing this.
No, go ahead.
I would like to put, if you have some kind of struts, you need to put struts like plates with cerclage around over there.
Okay. Yeah, I think that that's certainly an option. I always, when operating around a prosthesis, I will be the first to admit I don't, cerclage cabling in the femur or in the humerus always scares me a little bit for two reasons. I get worried about the neurologic structures, and I get worried that I'm not going to be as biologic friendly as I want to be. But I always am prepared to use cerclage cables, but it's not my first choice. Not being a joint replacement surgeon by total profession, and more of a trauma surgeon, I always worry about the struts and the dead bone, and I think that that's maybe a trauma surgeon bias. But it's never my first choice. It's not. I'm not saying it's wrong. It's just my personal bias is to try and fix things with what's there and avoid the struts. So that being said,
sorry, what do you think about a bridge plate with cerclage around along in superior part close to the prosthesis?
Yeah, I think that this is I think that that's probably the option, is a bridging plate around this prosthesis and maybe some cabling up here. But what I would point out is that we should look at what we have in our plating armamentarium that might help us avoid cerclage cabling. And so one of the things that I've discovered over time with these prostheses is, if we have the ability to use variable angle locking screws, sometimes we can get around the prosthesis. So in the upper extremity, I've looked for plates from different parts of the body that might help me achieve this. And the trouble is, we don't always have variable angle locking options in plates that are long enough. And so one of the plates I've come up to use is a distal tibia plate, like the medial tibial plate, because the screws, depending on the design up in the shaft, have some variability in where you place them. And so I've liked using this plate to do what you said, perform a bridge plating. And then I've been able to date anyways, avoid augmenting with cerclage cables or wires proximally at the prosthesis, because I've been able to get the fixation on one side of the prosthesis or the other. But one of the challenges with the plates is that since it's not a broad plate, it's hard to, sometimes the screws only want to line up on one side of the prosthesis. So I worry a little bit about a stress riser. And obviously, if you have a cemented prosthesis, it's easier to get fixation, closer to the intramedullary canal. But I think this is a good way to think, or a good solution potentially for these fractures, is to use, if you have access to a variable angle locking plate that's long, you can avoid the cerclage cables. So that's how we approach this, and we're developing a small series of cases, and you can either place the plate, you know, in the direction that it's placed now with the broad part down distally, or sometimes the broad part in, say, a hemiarthroplasty can go proximal and the shaft can come distal. So I don't think it really matters how you place the plate. The key is really having variable angle locking screw fixation to try and get around these prostheses. So this is a plate placed the opposite direction in another case where we placed the plate proximally and placed a lot of fixation, you know, with a shorter reverse shoulder up here. And these cerclage cables were previously placed, not placed by me.
Okay, but this is you make a rigid solution for this. There is no very important for biological solution to put the screws more so far from with this case, or the opposite, put very close to the screws. What do you think about?
I think what you're saying is you know, maybe we need more of a bridge plate and more motion for fracture healing to occur here. In this previous case, I think we do have a pretty long zone of comminution here. Mm-hmm. So I would argue that we've left enough flexibility here. Okay. I think, again, in the geriatric fracture population, it's all about, I'm not sure you can ever have enough fixation. So in the ankle, clearly I did not have enough fixation, not enough fixation into the tibia. The participants tonight have criticized me for not fixing the medial malleolus. So there, clearly I didn't do enough. Here, I think when you talk about bridge plating or creating biologic friendly fixation and motion at the fracture site, I think you really have to do it with the length of the plate here. Okay. And not necessarily, you know, I don't think you should cheat on the number of screws you put into the poor quality bone. So maybe a longer plate and screws further away from the fracture site, but I would just caution you that I don't think you can't get enough fixation in poor quality bone. That's all I would say. And I do see here we have a pretty long segmental section of fracture here, so that should be enough, I think, to get secondary bone formation. But perhaps you're right. The criticism here is maybe I should have used a longer plate and with a more simple fracture and moved the screws further away. I don't think this patient came back, so I don't know if it worked or not. But just wanted to illustrate a lot of different techniques and using plates made for different parts of the body, because in the end, they're just plates. But if we think hard enough, we can find other uses for them. Other comments? So hopefully this gives you some ideas for the upper extremity periprosthetic fractures. Here's just another x-ray of another case, I think. Again, here we did go for absolute stability in this case with lag screw fixation. And there again, you see a long plate. And here, clearly, we did not go for bridge plating. I mean, we went for absolute stability. So just some thoughts before we move down to the proximal femur. So here's I would say not an uncommon problem in the U.S., which is a fracture of the proximal femur with a loose prosthesis. I think in this case, this was a hemiarthroplasty. And I have a technique for dealing with these that, you know, maybe is a little beyond fracture fixation. But when I see a loose prosthesis, I always think about a revision prosthesis. And I think about using the revision prosthesis as a nail. So I like a long prosthesis, and I want to deal with the fracture in this area with an intramedullary device. So that's why I choose a long prosthesis. And here you see, in this particular case, the revision component. And I think what started out as a relatively simple fracture pattern in poor quality bone went south very quickly, because when we were trying to do the revision case, we ended up with some additional fracture fragmentation down the leg. And so eventually you run out of room with what you can do here. So you see a surgeon in trouble here in poor quality bone, because you start to see a lot of different things happening. You see cerclage cables, and then you see, if you look closely, eventually we had to cement this prosthesis in to try and get some stability. So the moral of this story is that even when you have the best intentions of using a intramedullary device, sometimes in poor quality bone, you need to use everything you have at your disposal, even if that's not what you intended. So the cerclage cables, the cementing technique to get stability to allow early ambulation. Here's another case that went a little bit differently. I think these prostheses are difficult because they're wedge-shaped. If they don't get bony ingrowth over time, they act like a wood-splitting device. And if the patient falls or stumbles, they just split their whole femur. Clearly, this is not well fixated. And in this case, here you see the technique where we do use some cables to reconstitute the intramedullary canal, and then we use the device like a nail for this part of the fracture, and we get stability distally. But again, here's my use of cerclage cables, judiciously placed and early weight bearing. Any comments on these two cases? Anybody do anything differently? I don't think you can. So ultimately, sometimes these things heal even with good technique, and sometimes they don't. So here's a case that I think is interesting. So this is a periprosthetic acetabular fracture. And this is on a young patient. So this patient was sent to me. They did the hip replacement. They recognized a post-operative complication. So what do you do with this? This is relatively acute. You see the staples are in place one day after this fracture. I think, you know, like a 65-year-old retired school teacher is what this was. What do you do with this?
Oh, probably I used to make a revision on the acetabular. Probably put reconstruct the acetabular wall, maybe with a burr Schneider, and to put in a different cup over here. Maybe with strut or hydroxyapatite strut.
Okay.
And probably, or a kind of burr Schneider.
Okay. And you would do that all at once. You'd fix the fracture and put a new acetabulum in there.
Yes, yes.
Cement it into the cage.
Probably cemented it. Probably
cage,
cemented.
Yeah. Okay. Other comments or techniques?
Maybe we can use trabecular metal. I think it's better than Schneider.
Okay. So you would fix the acetabulum or just push the trabecular metal into the...
I use it to put bone graft.
Okay.
And I associate with the trabecular metal.
Okay. All right. Reasonable. Any other comments? So I get a little worried about, in geriatric fracture patients with acetabular fractures, I think, you know, for the older patient, maybe fixing the fracture and doing an acute total hip might be reasonable in special circumstances. But in younger geriatric fractures, even with poor quality bone, who came to see their surgeon for a joint replacement for arthritis, I'm really thinking about how can I get them the best joint replacement outcome possible. And so I worry a little bit about doing all the things that were mentioned and not getting a stable acetabulum. So what about fixing the fracture and waiting on doing the revision acetabulum? Does anybody think about doing that? Because I always worry a little bit if you put a cup in there and you put a lot of pressure across the hip joint, you know, are you going to really get stable fixation even if you use trabecular metal? So I have a technique I learned from one of my mentors that I consider using occasionally. And so this patient also, for whatever reason, after their initial surgery by their initial surgeon, had a post-operative sciatic nerve palsy that developed over time. And so what we ended up doing is she was transferred to us, and this was the amount of displacement at the time of transfer, so you see things are moving. And so my thinking was, let's decompress the sciatic nerve. So we opened her up, and there really was no hematoma there, so probably a traction injury. And then I took the acetabulum component out, and I fixed the acetabulum. And then I filled the acetabular hole with antibiotic impregnated cement. And I took the loose prosthesis out and capped the femur. And so I didn't want any pressure on the acetabulum. And the reason I took the femur out is that I knew when I was going to revise this, I was going to want to have a component that allowed me to dial in some rotation, some anaversion, so I could create stability in the hip. So simple plates, a reasonable reduction of the acetabulum, not perfect, and we allowed that acetabulum to heal over time. And then we came back, we confirmed healing with a CT scan, and then we went ahead and in a delayed fashion, I believe 3 months after the fact, we performed a revision hip replacement, and we used a modular prosthesis so we could dial in anaversion to create stability to prevent dislocation. And so that was how we approached that case. So I like that technique on younger patients who can tolerate having to use a walker or have some limited ambulatory status, even in poor quality bone. And I think it works out pretty well to get a stable replacement later. But open to your criticisms. You won't hurt my feelings.
Dr. Steve, during these 3 months from the first surgery to put the hemerotrophy, did you left the patient with any kind of traction?
No.
No?
No. Very tough lady from the farming community. She went home. She ambulated on a walker. We did allow her to shorten. I think this, you know, shows you the degree of shortening here that she had at the time of revision. So you're right, they definitely shorten. But since she'd been living at an at-length state, and this wasn't going to be a long period of time, generally you don't have to worry about significant contracture or nerve injury when you bring them back out to length.
Okay.
I like the cement for a couple of reasons. It makes the revision surgery, the revision hip replacement, all you have to do is find the cement, and the cement preserves the acetabular socket, so you don't have to spend a lot of time digging the tissue out of the acetabulum, and the same on the femur side. Other options, if you're worried about this pushing on this, you can put a plate across the front of the acetabulum, or if you chose to revise the acetabulum at the time of the fracture fixation, but you want to keep the pressure off of it, you can put a plate across the front of the acetabulum to try and protect to try and create a jail to keep people out of the acetabulum. But I haven't found that necessary to do. And the patient did well.
I would like to know, Steve, I would like to know about long stems for revision. Why you prefer this short revision femoral piece, stem?
You mean in this case you think it's too short?
Yeah, I think so. I don't know, because the anticurvatum of the femur, or what do you prefer, not so long?
Well,
until...
yeah, so this patient got I think I used probably an even longer stem than I would have ideally used because we had a crack here that developed at the time of the revision.
Yeah.
But one of the problems with these stems, these revision stems, is that they don't match the bow of the femur very well. So in the older patient with a periprosthetic fracture, if I can back up here, if that's okay, in these patients here, these stems aren't bowed very well. And as you know, in the older osteoporotic patient, these stems can impinge on the anterior cortex and actually cause a fracture over time or a stress riser.
Yeah.
So I really wish that this design was a little bit different. I wish they would make a bowed stem as opposed to a bend. They put an acute bend in the stem, but it's never enough distally. So I try to at least get 2.5 diameters below the fracture, but that one of the problems with the super long stem is that anterior impingement of the cortex, and I think that's a problem. See here, see on the lateral X-ray, it's not a straight stem. They put a bow in it up here or about right here, but it's never enough, and so the longer the stem, the more you're pushing on the anterior cortex. So that's why I try to avoid a longer stem if I can.
Yeah, some of them they have stems with bowing, with anterior bowing, no?
Yeah, there's some out there that you can use, and that might be a better stem.
Yeah. What approach you really use? This posterior?
Posterior.
Or what approach?
Well, in these periprosthetic fractures, I tend to use the approach that was used for the initial placement of the stem. But if I have a choice, or if they did an anterior approach originally, I'll try and stay anterior.
Okay.
Because it just really minimizes the dislocation risk. But I think the one advantage you have of a modular stem is that you can dial in the rotation that you want. So if you end up with a posterior approach, I think it's very important to have modularity so you can antivert the stem to prevent dislocation.
It's a porous coated stem?
Yes. Well, it's a ridged porous coated stem, grit blasted stem distally.
Okay.
This particular device.
Okay, thank you very much indeed.
Sure. Well, I would just say thanks for entertaining my presentation and joining in. Hopefully, I've shown showing my humility and letting you know that I have failures, and we all have failures. I think that's how we learn, is we learn through experience. And so I wanted to share that my failures with you and some of the other things that I've learned along the way that I hope help you in your practice for taking care of what I think is a very challenging group of fractures. Anybody can operate on good quality bone, but it takes a real surgeon to take care of people with poor quality bone. And hopefully you got something out of this and learned a few tricks.